I'm Howard Herrell. I'm a obstetrician gynecologist in Tennessee, and we're going to talk for about 20 minutes about global women's health issues and really women and children's health issues in developing countries. We'll try to learn a few things. Why do mothers die in the developing countries? What are the gaps in health care and issues related to access to care that are related to maternal death, and for that matter to neonatal and child morbidity and mortality? What interventions are easiest to implement, and what are strategies for that provide sort of the most benefit for the cost? What are the barriers to doing that? What are the barriers to access of care for women and children? And how does breastfeeding in developing countries relate to maternal and child health? So maternal mortality in developing countries lags far behind that in countries that we call developed countries, in Europe and Australia and the United States, etc. I think there's some insights to be gained about how we developed interventions that led to a positive impact on maternal mortality in the United States, because if you go back and look at 1850, 1880 United States, you'll see similar child and maternal infant morbidities and mortalities in 1880 America as you see today in several sub-Saharan African countries, for example. And sometimes there's something to be learned about that in terms of developing strategies and understanding how we get to first world outcomes in developing nations. So slides like this are popular where you see rates of maternal mortality in the developed world. You'll notice that the United States is towards the right, and there's some issues about how you count mortality and things like that. But these are for the most part developed countries, and you'll notice that even in the far right of this graph, we're around 20 women per 100,000 live births. But now compare that to maternal mortality in developing countries, where to the far right now we see Sierra Leone with a maternal mortality of 1,400 or so per 100,000, dramatically different. And the worst countries for maternal mortality you'll see are the Central African Republic, Sierra Leone, Chad, Nigeria, etc. We'll talk a little bit about Nigeria and access to care in a few minutes. But you can see by the map that Central Africa, Sub-Saharan Africa, and certain parts, at least, of Western Asia are endemic areas for maternal mortality, compared at least to Western countries. In the United States, maternal mortality, as I said, has dropped dramatically over even the last 100-plus years. We have our struggles with it, but just you can see that it compared perhaps to many of those countries to the right of the graph we saw above, even by 1900, and go back 20 or 30 more years, and Sierra Leone and the United States had something in common for sure. So what are some of the interventions that's led to the decrease in maternal mortality, and with that, I should say, perinatal and infant mortality in the United States? So you can see here from 1840 to present day some of the things that have been invented. A lot of it has to do just with the implementation of modern obstetric practices. The ability to have anesthesia available allows you to be able to do cesarean deliveries and other surgical interventions for, say, ruptured ectopic pregnancy or septic abortion or things like that. But along with all that, you also have to think about other societal advances in terms of things like the ability to have milk pasteurization available, the ability to have, we'll see a second, clean water and sewage systems. But specifically in obstetrics, we developed a lot of technologies in the last 150 years that have led to most of that reduction. And just easy enough, those technologies are not readily available in the areas where you see incredibly high rates of maternal mortality. It's an access issue. You can't give blood transfusions and cesarean deliveries and safe anesthesia and uterotonic drugs to control hemorrhage if you don't have a hospital or a hospital clinic-like setting in which to deliver them. And even if you have that setting, if women are too far away in their time of need to get there and make use of them, there wasn't a lot of point. Antibiotics, obviously a huge impact in maternal mortality. And you end up with needing to deliver a certain number of women by cesarean delivery, etc., a certain number of women treated with uterotonic drugs and antibiotics to have an acceptable rate of maternal mortality. And all that implies birth near a hospital or birthing center or in a hospital or birthing center. Mortality for infants, so infant mortality is death from birth to 12 months of life. Here's sort of the same trick. You see Western countries here. United States, again, is over to the right, and I won't get pedantic about that, but that has some to do with definitions. But overall, you see pretty good rates of infant mortality in the Western world, with Iceland and Japan and Monaco over to the left, and most European countries squarely in the middle. But again, if we go to the right of that graph, you see towards the right now Afghanistan and Somalia and Mali, and again the Central African Republic, etc., Nigeria, and still over towards the right there. So infant mortality hugely different from perhaps, as you see there, 5 on the bad side in Western or developed countries to rates as high as 110 or so in Afghanistan. So other things important in that regard, vaccines, hugely important in infant mortality. You see high rates of vaccine-preventable diseases as causes of death. Improvements in sanitation. This is, again, a look at what we've done in the last 150 years in developed countries, and the United States in particular, but improvements in sanitation with water filtration systems, chlorination systems, milk pasteurization, etc., have made probably the biggest impact of all in terms of the old causes of death in the United States, or the new causes of death today in a lot of developing countries, diarrheal diseases in particular, and sepsis, etc. And improvements in sanitation and water filtration and availability of clean water and then just nourishment. We never had much of a malnourishment problem in the United States, but undernourishment and malnourishment continues to be a leading cause of death, or at least a contributing factor to disease vulnerability in developing nations. And a lot of other high-tech stuff too for kids that are in trouble. Again, this is an access issue. A child in trouble in the United States isn't far away from a neonatal intensive care unit that can provide innovations like high-frequency ventilation and surfactant for the lungs and things like that. We eliminated malaria in the United States with DDT, something that many developing nations haven't had an opportunity to do, and so they're still plagued by malaria and other infectious diseases due to mainly to sanitation issues. So about 90% of all maternal and infant mortality occurs in the third world, and literally a maternal death happens every minute. Over 500,000 of these are in developing countries, these maternal deaths. And about half the deaths for newborns or for mothers, occur within about the first day of birth, meaning that their access to birthing centers or hospitals or settings like that where some interventions could be afforded to them realistically could save at least half, and probably much more than half. We think that 80% of these deaths are preventable. So what do women die of in these developing countries? Well, you can see that many of them die of pre-existing and untreated medical conditions, and in Africa in particular, HIV/AIDS is an issue, as well as malaria, but diabetes, hypertension, other things you might think of. But the largest, immediately preventable condition, you see 27% is related to hemorrhage in and around the time of delivery. Hypertension, eclampsia, we almost never see deaths in the United States from eclampsia or hypertension, but in Africa, hundreds a week die related to this. Infections that are mostly treatable, obstructed labors, inability to have surgical deliveries, complications of abortions, and all things that we really don't see that often in the United States, and 80% of which we think are preventable. Unintended pregnancies, at least a fifth of maternal deaths occur related to unintended pregnancies, and 2/3 of those occur when people try to procure unsafe abortions and have septic abortions or things like that. So effective birth control in itself is a simple and effective way of dramatically reducing maternal mortality, along with controlling the spread of HIV/AIDS. And of course, death doesn't tell the whole picture. Morbidity is there too. For every woman who dies related to pregnancy, another 16 suffer usually preventable severe complications. So there's always been two approaches to fix these issues. One is a sort of top-down approach, where you build systems and change governments and build infrastructure. And another is a bottom-up approach that focuses on, education and mission-based, service-based delivery of care, and the two systems sometimes clash. If you're looking at what can you do for the highest value impact, basic services that you need to have a woman deliver a child safely include the ability to give IV antibiotics, the ability to give drugs like oxytocin to both induce labor and to treat hemorrhage, the ability to give drugs to help women who are having eclamptic seizure or treat blood pressures, the ability to remove the placenta when it's retained, and other products of conception, particularly with septic abortions or infected uteruses, the ability to do operative vaginal deliveries, and the ability to do at least very basic neonatal resuscitation, and at least close by ability to perform a C-section or give a blood transfusion for women who need them. A lot of care on the ground focuses on training skilled birth attendants, which I think is a wonderful approach, and the World Health Organization has a manual for training birth attendants, as does Medicine Without Frontiers has a manual. They're both excellent. Maternal mortality has a big impact on societal structure. Dead and sick mothers don't educate children. Marginalized women come to reflect the societal and governmental priorities of that nation. Female participation in government and workplace, we can see, are surrogates for maternal mortality. And a decrease in maternal mortality has followed suffrage in most countries, and an increase in education access has followed a decrease in maternal mortality. So these things are all intricately related to other societal measures. Africa, as an example, a third of girls are married before the age of 18. A third of girls have a child by the age of 20. 31 million girls of primary school age and 32 million girls of lower secondary school age are out of school related to pregnancy issues. And only 2 of 35 countries have gender parity in school. Before I talk about breastfeeding for a moment, just talk about some of the barriers to a top-down approach and why access to care is problematic. And it's money, it's infrastructure, it's roads, it's building of hospitals and clinics, and the universities that train doctors and nurses, etc. There's just vast amounts of infrastructure that's missing, and there's vast amounts of economic dollars there. In sub-Saharan Africa, the average per capita expense on healthcare is $31, and that compares to an average per capita expense in most developed countries of around $3,100 per capita. So a huge difference in the capital outlays there. There's no insurance coverage. There's no expense for the average person to have any of these services, although there is progress being made in sort of national health policies in Senegal and Ghana and the Ivory Coast and Kenya and Benin and a few other countries. The Gates Foundation has encouraged a lot of this, and vaccination and the things that are relatively high value and inexpensive are happening, but the dollars aren't there typically to fund care, and then the access isn't there, because even if you're in Ghana and you have some health insurance, you may live 6 or 7 hours away from a hospital, and for a woman or who's giving birth, or for a small child, it might as well not exist, because they don't have the transportation, the roads, reliable transportation, etc. They don't have the referral system, the ability to get there. So there's tens of trillions of dollars of infrastructure cost that separate what we do in developed countries from developing countries, especially in sub-Saharan Africa. And so this ends up being a multi-generational economic expansion that's necessary. I will mention breastfeeding. And so breastfeeding exclusively up to 6 months of age that provides all the nutrition and everything a child needs. And it protects against, because it's clean, it's not contaminated water mixed with porridge, it protects against sepsis, pneumonia, and diarrhea. We believe that optimal breastfeeding can prevent 12% of child mortality, just optimal breastfeeding, meaning exclusive breastfeeding for at least 6 months. Only 36% of children worldwide are exclusively breastfed for 6 months, and the rates are lower in the Western Pacific and Sub-Saharan Africa, where the impact, particularly related to diarrheal diseases, could be tremendous. There's a couple of things that are recommended, and one is initiation of breastfeeding within the first hour of birth, because that's going to be a predictor of long-term success, and also transference of colostrum and antibodies and things like that's critical in that time. But you see this map, the brighter the colors, the poorer, and you see in a lot of the countries of concern, breastfeeding within the first hour occurs less than 40% of the time, fairly consistently, and very few places in the developing countries have a greater than 60% rate. And this is like low-hanging fruit. It's easy to encourage, and everything you need's there to initiate breastfeeding within the first hour. But then that's going to carry over into success for 6 months. So here you see the red colors are the worst colors. So less than 20% of children in the countries with red, and 20 to 50% in the countries with yellow, are actually breastfeeding exclusively at 6 months. So that, again, in countries with poor water supply and hygiene issues and other nourishment issues, opens up those children to significant health disadvantages and significant morbidity and mortality. Children can get everything they need, nutrition-wise. Now, of course, that means the mother has to have the appropriate nutritional status to be able to breastfeed, and appropriate health status to be able to breastfeed. And so malnourishment or a lack of resources for nourishment may still be a problem. But when children are not exclusively breastfed, those issues are magnified much more in terms of the focus on the infant rather than the mother. So breastfeeding in the United States, we complain about exclusive breastfeeding and things like that. But in not breastfeeding exclusively your child in the United States is unlikely to open the child up to significant malnourishment or diarrheal diseases or sepsis. But not breastfeeding in developing countries can do certainly that. So lots of progress to be made, lots of low-hanging fruit in these developing countries still to be plucked. Breastfeeding and exclusive breastfeeding optimization is a great place to start, and by itself can have a significant impact. Vaccination programs obviously have a huge impact. And then development of birth attendants with minimum essential supplies could have a dramatic reduction in maternal mortality, and reduction in maternal mortality is associated with improvement in education and women participation in government and governmental structure, etc., and can make generational impacts. So that's what you get in about 20 minutes. Feel free to email me with questions, and all of these issues deserve a deeper dive if you're interested in them. Thanks.